Good morning, everybody, and welcome to the InTouch Health webinar series. This is Scott Young, and I'll be your host for today's webinar. Today, we'll be featuring Kate Baars and Caroline Raganit of Providence St. Joseph Health, and they'll be presenting on their TeleICU experience. Kate is the Product Director for Telehealth Acute Care for Providence St. Joseph Health, currently including the TeleICU and Telehospice service lines. Prior to her current role, Kate was with the PSJH strategy team, working with a variety of divisions and stakeholders across the enterprise to advance their strategic initiatives. She is energized and fulfilled by the opportunity to build partnerships and develop programs that enable clinicians to better support one another and provide patients the best access and care possible. Caroline is the RN and Senior Clinical Program Manager for TeleICU with Providence St. Joseph Health's Telehealth Division. She holds a baccalaureate nursing degree from the University of Washington and has been a registered nurse for 20 years, with a background in critical care nursing. Prior to her current role, she managed an inpatient telehealth program at Swedish Medical Center in Seattle for 10 years, including TeleICU services, remote cardiac telemetry monitoring, and continuous patient video observation across 6 hospitals. We'll begin the presentation shortly, but first, a few notices. You have all been auto-muted. If not, please make sure you mute yourself. At the bottom of your audience console are multiple application widgets you can use. If you have any technical difficulty, please click on the Help widget. It has a question mark icon and covers common technical issues. You can expand the slide area by clicking on the Maximize icon on the top right of the slide area or by dragging the bottom right corner of the slide area. During the webinar, you'll be able to enter questions in the Q&A widget located on your audience console. Questions will be answered at the conclusion of the presentation, so please feel free to ask your questions at any point throughout the webinar. If a fuller answer is needed or we run out of time, questions will be answered later via email. This webinar will be recorded, and a copy of the recording will be available on our website and sent via email. This webinar presentation should not exceed 60 minutes, including time for questions and answers. And now, I'd like to turn it over to our presenters.
Thank you, Scott, and good morning, everyone, and good afternoon to any of you that may be on the East Coast. Before we jump right into just orienting the audience to who we are as a system and as an organization, Caroline and I just wanted to take a moment to thank folks that may be listening in on this webinar who were involved in this pilot project. It always takes a village to come together on any project worth sharing, and we've got some folks from the hospital in question as well as members from the telehealth team, and so just a really heartfelt thanks because Caroline and I are representing this project, but it took many, many hands and a lot of effort. So if you had a hand in this, you know who you are, and thank you so much. As Scott mentioned, Caroline and I are here to discuss a TeleICU project that we initiated around this time last year. But before we jump into that, we wanted to give you just a little bit of context for who we are as a healthcare system. So Providence St. Joseph Health is a not-for-profit healthcare system with 51 acute care hospitals and a broad network of clinics and services in the western United States. So our geographies span Oregon, California, Washington, Alaska, Montana, Texas, and New Mexico, and we have some affiliate partners in those surrounding geographies. And our care system has a long tradition of meeting new challenges by pioneering new solutions, from our founding by the Sisters of Providence and the Sisters of St. Joseph of Orange, who brought healthcare and social services to the West, to present day. And telehealth and virtual care is a huge priority and investment for our organization, really as a means to make phenomenal care simple, accessible, and affordable to those we serve, and being able to meet our patients' needs where they are and make the best use of the clinical talent that we have within our system. And Swedish Health System is a part of the Providence St. Joseph Health family and is the largest healthcare services provider in the Seattle metro area. And Swedish as well has a long history of embracing innovations in care. I'm going to turn it over to Caroline, who's going to talk a little bit more about the situation at hand.
Thank you, Kate. First of all, I would like to talk about Swedish Edmonds campus. That was the hospital that we chose to select for our pilot. A few quick stats about the hospital. It's a 217-bed suburban hospital with a 13-bed ICU with an average daily census in the ICU of 7 patients. The patient acuity for this hospital is relatively high for a suburban hospital. They have an active cath lab. They're able to take care of critical care patients who are in on intra-aortic balloon pumps, continuous dialysis, and ventilators, etc. The transfer patterns with patients who need more higher care, we have a hospital at Swedish First Hill campus, which is about 17 miles south of the Edmonds campus. If necessary, we would transfer the patients to the higher level of care to downtown Seattle. The staffing model that is in place is currently, before the pilot, we had an in-house intensivist during the daytime with no in-house intensivist at night. The intensivist at night is on call but not on site. The Swedish TeleICU program has an infrastructure for supporting other campuses, but was only supporting the Edmonds campus with phone-only support at night. So the challenges that we were facing was the clinicians had limited ability in supporting the local Edmonds staff without seeing their patients. And as you know, many TeleICU models can require significant upfront, ongoing investment, and lack of flexibility for the models that are out there that we've seen. So we talked to Edmonds because we wanted to provide the same standard of care for the other hospitals that we provide service to as a TeleICU, and we worked with them to design a TeleICU program to solve for these challenges and to take advantage of the demonstrated benefits of the TeleICU. And to share some quotes from the TeleICU intensivist, Edmonds intensivist, and other staff that we surveyed before we went live with the program. So a little more about our pilot program design is that the TeleICU program that we have bridges a nocturnal coverage gap that we have for certain hospitals. We pursue a proactive collaborative model versus an episodic model. So for the TeleICU, we provide continuous monitoring. We have nurses that are rounding and watching patients continuously 24 hours a day. And then at night, we have a physician, a board-certified pulmonologist, critical care doctor who also provides care at night and that is awake and monitoring patients. When we built this program, we provided clinical discovery to provide role clarification and clinical integration. This was key to our program because the hospital has their own workflows and their own ways of taking care of patients, and we wanted to make sure that we were supplementing that care, and we also wanted to make sure that we knew their workflows. So, for example, our clinical discovery questions was, how do the hospitals take care of patients, working through a code response? Who does the procedures at the bedside, or if the patient needs to have a procedure away from the unit, how is that process? Another clinical question that we ask is, who is the first to call from the ED for an ICU patient admit? So working on those workflows as well as the RN workflows are things that we would outline during our clinical discovery and we would work through before we implemented a program with the hospital. We also required bidirectional audio-video, which is a reliable and user-friendly platform. So what we were looking for this was a strong, seamless network with a camera that had pan-tilt-zoom capabilities that the clinicians can use during their conversations and interactions with the bedside staff. This technology would be something that is the last piece of the program that the clinicians at the bedside need to think about when dealing with high acuity patients. So when our providers and our remote clinicians, our nurses, are in the middle of a clinical encounter, worrying about the equipment working or not working should fade in the background. So we were looking for that infrastructure and found that and used that design as part of our program. And next is Kate to talk about the measurement and results.
Great, thanks, Caroline. So as I mentioned, we went live in partnership with the Swedish Edmonds team with this TeleICU pilot about a month ago, and we really took a lot of effort up front before going live to hammer out with that leadership team at the facility, how would we be measuring this pilot, what framework would we use, on what time horizon would we be measuring things, and what would be the duration of the pilot itself. And so I wanted to share some elements of that framework with those of you on the phone, and this should look very familiar to many of you. So, whether you come from a clinical background and you're thinking in terms of a quadruple aim, or from a business background like me and you're thinking in terms of a balanced scorecard, we wanted to, to kind of outline against each traditional measure, so looking at access, experience, quality, and cost of care, how would we actually assess that metric? And we started with, as you probably can imagine, just a broad swath of potential measures and how would we evaluate access or quality. And we really wanted to hone into to kind of a core set of measures that for the purposes of this pilot program would be most beneficial in gauging success. So for access, we evaluated that looking at an increase in the utilization of and engagement with the TeleICU service, which we had the great fortune of having a baseline already established in terms of the phone-only support that the TeleICU had been providing to this campus. So looking at what the delta was there, and we determined that we would assess that on a 30-day horizon, which was the duration of our pilot program. And going into this, we thought, we probably would see some cannibalization between, audio-video consults versus phone-only. There would probably remain, some phone consults, but we thought it would be just amazing if we could increase those interactions by 25%, up to 50% between those two sites. So that was kind of our barometer. For care experience, we looked at, we really wanted to provide our staff, obviously, and as well as the physicians, both on-site and in the TeleICU command center, with a really great experience using this model. And so to assess that, we evaluated it using a qualitative survey that we surveyed before the pilot. So Caroline shared some of the results and responses from those various groups. And that survey we elected to send out to a handful of different stakeholder groups. So it went to the TeleICU team, so in the remote command center. It went to the on-site nursing staff at Swedish Edmonds, to the daytime intensivist group at Swedish Edmonds, as well as to the nighttime hospitalist group at Swedish Edmonds, to really get some, just general sentiments from that group ahead of time about what they were looking for, what they were concerned about, and what would be really great to see from this pilot to establish that baseline. And then we determined that we would survey those same groups again towards the end of that 30-day pilot and assess, those deltas and feedback, but more of a qualitative measure there. In terms of quality of care, we wanted to assess this looking at a decrease in ICU mortality. And this measure we determined that we would assess on a 6-month horizon. So knowing that we were going to run a relatively short duration pilot, we didn't want to, there can be so many variations both for this and then our next measure, hospital length of stay and assessing cost of care, that we wanted to make sure that we had a longer horizon to look at this measure so that we wouldn't be accounting for any natural fluctuations in patient acuity or anything else that really could be driving these changes. So looking at a 6-month horizon. And there again, outlining our goals. There are so many so many benefits to having a TeleICU program in terms of access and experience. But really setting out on this, we had discussed, if this stays, if it stays the same, that's fine. If we move this at all in a positive downward direction, that's fantastic. Those are great results. And so we were really, wanting to stay close to that measure, but knowing that really any improvement we see is a great success. So I'll take you a little bit into the actual results that we saw, but wanted to lay out that framework to give you a little bit more context for how we were looking to assess results. Alrighty. So I did want to just talk a little bit about that pre-pilot baseline when we're talking about utilization. And as you can see from this chart, you'll see that prior to the pilot go live, we actually were seeing some pretty robust utilization and engagement between the remote TeleICU team and the on-site team at Swedish Edmonds. So looking at the 30-day period prior to go live, we actually saw 306 phone calls in that 30-day period back and forth between the TeleICU and the recipient site. So they were averaging, just upwards of about 10 calls a night back and forth. So definitely using the service and had those relationships there. However, when you look post-go live, so assessing that on the 30 days after we went live with this project, we were just astounded by the results that we saw, because we actually saw, rather than that cannibalization that we thought might occur, we saw both the phone calls increase. So we went up from having about 10 calls back and forth to between 15 and 16 calls per night on average between the TeleICU virtual team and the Swedish Edmonds team, in addition to having on average about 6 or 7 daily demons using audio-video encounters over the InTouch TV Pro. So we actually saw an increase plus an additive benefit of having those video encounters post-pilot. So looking at total engagement, moved that needle from 306 engagements back and forth between the two teams in the 30 days prior to 643 in the 30 days post-pilot, so about 110% increase in total interactions. And what I think is especially impactful to point out to this group, if you look at this chart with the trend lines, is that if you look at this dark blue area, that's actually representing the census in the ICU at Edmonds over that pilot period. And you'll note that there was a drop in census over this time. So despite a downward trending census, I think that makes that 110% increase in total interactions really all that much more powerful. Speaking a little bit about the engagement and experience, I won't read these quotes to you, but we wanted to pull out a couple of highlights that stood out from the feedback and reaction from the teams that I mentioned that we surveyed in asking them again post-pilot, now that the service is live, what do they like, what don't they like? And I do think it's important to mention, I should have noted this earlier, that we did this on a blinded basis, so this was completely anonymized. We would have been able to tell based on the survey that they received and who it went out to whether this person was, a nocturnist or a day intensivist, a member of the nursing team. But beyond that, we didn't have any way to, to assign this to any given individual. We did leave an option for those folks to actually type in their name electively if they had something specific they wanted to follow up on. But really wanted to give folks the opportunity to have space to be as candid as they felt that they needed to be without it being identified. So you'll see some major trends here. I mean, just first and foremost, in terms of the service being a wonderful safety net for folks at this site in terms of offering support in managing those patients at night, and being really important, especially in supporting the nighttime nurses and having someone available and readily responsive to help them managing those patients. And one of the things that, in Caroline's and my experience talking to potential new sites that seems like is raised as a potential concern prior to going live with this program is concern from on-site hospitalists that having a virtual intensivist managing patients in the ICU might result in additional work for them, or having to run back and forth between the floor and the ICU to manage those patients or help with procedures. And so we did want to be really mindful of asking the hospitalists in these surveys about their workload and how they felt their patient safety was impacted, whether they were comfortable with the service and whether or not it had a positive impact. And again, just positively surprising results. We were thrilled to see that out of our surveyed group, 100% of the team of nocturnists at Swedish Edmonds agreed or strongly agreed that the TeleICU support increased patient safety, and 100% agreed that they were able to spend less time in ICU, decreasing their overall workload. So we felt that was pretty significant. So moving back into our framework here and kind of updating these with the results. So we were, you may recall our pre-pilot goal of, we thought it would just be swell if we could increase this to 25% or 50% more interactions than pre-go live. So we were just really thrilled with 110% increase in interactions and 52% increase in phone calls alone over that time. For experience, our goal had been to have overall positive experience from the various groups of clinicians, knowing that in a 30-day pilot, often you're still working out a couple of kinks, knowing that we're not going to get just everything is fantastic. There's no improvements left to make, but we really wanted to feel like this was an overall positive experience, and we really felt that we exceeded that threshold that we set for ourselves. And now that we are significantly farther down the line from our pilot date and able to assess the hospital mortality and length of stay measures on a longer-term horizon, we really have seen some positive downward trends, and they've exceeded our expectations for what the program would be able to deliver. So we've been very pleased with the results that we've seen from that additional additive support for the ICU at Edmonds as well. So we did want to wrap up with a handful of takeaways, and I'll go over this section, but I welcome Caroline to add in anything that she feels was really a takeaway beyond the things that we chatted about ahead of time. But we really had so many learnings from running this program, and so we wanted to share with this group really what we felt was incredibly impactful. And the first was really starting with your why, which sounds relatively obvious, but I think making sure that you keep coming back to why we're doing something throughout the entire program and pilot design is just incredibly important. And so our why, and I would argue or posit to this group that for any telemedicine program, this should be your why, and it just will vary with the service, is to design a technology-enabled clinical solution. And what I mean by that is ensuring that we're starting with and ending with the clinical needs, the workflows, and then finding the best technology solution to support those needs. So we've had the benefit of seeing this go down a couple of different ways, and it usually ends up with much stronger results if we really focus on ensuring that the service and program developed is clinically driven, and that technology is always a supporting solution rather than starting with, well, we'll just connect folks and then the magic will happen. We really have to put the full clinical programmatic elements in place. So that was just incredibly important, and huge kudos goes to Caroline and members of the Swedish team for ensuring that we really had all of that set up before go live. The second one that I wanted to just touch on is seeking buy-in and not consensus. Telehealth is very new, and I think in my personal experience, I've found that we never are going to get 100% of folks completely gung-ho and supportive and embracing an innovation mindset. And I think that to some extent that's wholly appropriate because our industry impacts patients' lives. Safety is always of highest concern, and of course we do everything we can to ensure that every program that we design is incredibly safe. But telemedicine often has, because of its newness and our industry's slowness to change, often has a higher bar for safety and kind of proving out utmost safety than other clinical initiatives do. So really starting with understanding the needs as we're looking to develop buy-in, and not thinking of these programs as being a one-size solution. So focusing on developing partnerships, building relationships, and really listening before we say, well, we've got this great idea, it's going to be great for your site, just let us in there and it's going to be wonderful. But really just focusing on those relationships up front. We've found champions to be especially critical. So we were really fortunate with the Swedish Edmonds team to have physicians and administrative leaders that really especially were innovative and leaned into this idea and were willing to adopt a pilot mindset and give the clinicians who were pushing this forward enough rein to design something and enough opportunity to try it out and really get that use case behind us. And lastly, I'll just touch on skeptics. We're always going to have them, and I'm going to borrow a little bit. Caroline and I are in Seattle, so we're going to borrow from our neighbor Amazon down the street. And some of you may be familiar with Amazon's leadership principles, and they have one that I think especially resonates in this situation, and that is adopting a disagree and commit philosophy. That we're never going to have 100% consensus on many of these initiatives, but if we can help folks to feel comfortable adopting a disagree and commit stance, and have mitigation plans, open dialogue, and get folks really willing to get on board, give things a try, and provide appropriate feedback mechanisms to continue to iterate on solutions, we'll be so much more successful in getting folks at least to the point where they're willing to look closely and then leap. The third takeaway that I'll just touch on briefly is to ensure that when you look to do a pilot, that you're designing a program and not a pilot. And I know that can seem a little counterintuitive when you're thinking, well, let's build some proof points, let's build a use case for a new service. But if you're focused on long-term sustainability and the design of the service, then there's so much mitigation of the potential risks that you can see with a pilot. So, really the purpose of a pilot from our standpoint is to test the agreed upon hypothesis, not to figure out if or how a program might work. Our patients are too important to adopt that mindset, and so really critical to success is investing the upfront work in designing a long-term program that's going to have legs long after the pilot and really be clinically viable. So my best advice to you is just to design with the assumption that whatever you're piloting will be permanent. And lastly, to choose your measures wisely. So we chatted a little bit about this when we went over some of the measures and metrics that we selected for the Swedish Edmonds pilot. But obviously it goes without saying that you should know your goals at the onset of a pilot so that you have the opportunity to establish those baselines, the specific measure that you're going to use to assess access or quality or what have you, the data source for that measure. And you may find this to be not the case in your system, but I know our system is large enough that we have just a wide variety of different tools, systems. Largely, many of our hospitals are measuring the same things, but they may be pulling data from slightly different sources or measuring things in slightly different ways. And so understanding that you have agreement with your pilot site on exactly what the source of the data is going to be and how you're going to go about making sure that your assessment is apples to apples is incredibly important. So really get specific with your hypothesis and the expectation for achievement, and be realistic about what are the things that you have good enough data that is consistent enough between sources to measure adequately. Ensuring that, also important is going to be ensuring that you really hammer out what success looks like. So, for example, if you set a performance threshold and that threshold is met, is the plan that the pilot is going to automatically continue? Or if a target is missed, is the program worth continuing for other reasons and iterating on? And what are those reasons specifically that you might choose to continue a program that may have fallen short of an identified threshold? So really setting yourself up before a program is live to take the emotion out of the challenging decisions about whether that program is to continue or not is especially beneficial. And with that, that concludes the kind of formal presentation part of our hour. And Scott, I'd love to turn it back to you and open it up to some audience questions. Thank you all.
Great. Thanks, guys. That was great. We're getting a few questions in, but right now, just a reminder, if you have any questions you'd like to submit to the panel right now, to please use your Q&A widget on your audience console. So I think where I'd like to start right now is with the success of this program, if there's been any look into expansion opportunities.
Thanks for the question. Go ahead, Caroline.
Hi, this is Caroline. So when we first piloted this last year, we did start expanding the pilot, and we went live with another hospital within our system, and it was Holy Family in Spokane. So they are another site that we're using the same model and same infrastructure for. So we're looking at their numbers and their data and feedback from their staff, and they love the program and how we set it up. So we're slowly looking at different sites to assess the need, and we'll follow where the needs are as we're building the system to scale.
Excellent, thank you. Did you have anything to add, Kate?
No, I was, Caroline was asking me the same thing because I was smiling over here and thinking that, it's a huge testament to our clinical teams that do the clinical integration with these new sites, because we've had the great fortune at the sites we've we've discussed this program with, that we've developed really strong partnerships with the nursing leaders especially, as well as a few others at the sites where we have this model live, such that they're coming to us and asking, how they can help us evangelize this service and how they can support us and who they can talk to. And so it's really been a neat thing to see and a huge testament to our clinical team.
Great. So another question that we got in here was, what was the process you guys used to be able to track these phone and video encounters so you could measure the data and compare them later on?
So with the phone data, we use the old-fashioned manual count. So we have a count that is on our desk phones, and we manually counted that at the end of every shift. And it got a little hard to do because people use their cell phones, and we didn't know, if the cell phones were for which campuses, which calls, or if it was a staffing issue and one of our staff calling. So we looked at the numbers that came from the area code and the prefixes from the Edmonds campuses, and we also knew what the Edmonds phone number was. So those were the numbers that we called for sure, that we counted. So actually the numbers could be slightly higher, but we only wanted to manually count the numbers that we know belong to the Edmonds phone. So that was a manual process. And for the InTouch video encounters, the beam-ins, the software gave us a raw spreadsheet where we can filter through the data and see the users, the equipment, and the length of the beam-in interaction. So we were able to use both data for that. For the patient census, we also manually counted at the end of every shift to include all the patients that we interacted with, specifically for the Edmonds campus. And then we also compared it to other numbers to make sure that our source was really close to the patients, because some of the patients were overflow patients that we weren't necessarily counting, so we wanted it to get more true to the actual ICU patients. So we did that process beforehand, during, and after.
Awesome, thank you. So we're getting a question in here that's curious around the cost of care and resources required. So specifically they ask if the implementation at Swedish Edmonds allowed for reduction in hands-on FTE resources, or if those were offset by the additional TeleICU providers. And then also goes on to ask, does the program add FTE resources that are then offset by reduced length of stay?
Yeah, so thank you for the question. In terms of the cost of care and the resources required, we were pretty fortunate because the Swedish team has an existing command center and had capacity to take this on. That in many programs like this, one of our main drivers of that cost of care is staffing. So we were fortunate that we were able to kind of absorb this without a huge increase in terms of the TeleICU staffing to cover this. And then looking at cost of care from a metric standpoint, we were looking at length of stay and the reduction there. And so without going into too much granularity, we're looking at kind of the average cost of a patient day in ICU. So looking at both, the on-site labor costs as well as pharmacy costs, supply costs, room and board, kind of all of those additional elements that go into the aggregate cost per patient day. And then looking at applying that reduction in length of stay to that daily cost, as well as backing out, if that patient transferred to a lower acuity care setting, with lower costs of care, kind of what that delta is. So again, without getting super weedy, if we know that length of stay has been reduced by a half day, we're able to make some assumptions based on the data that we have and back out of that. And Scott, I'm not sure I answered all elements of that question. I think that was
I think that was good. I think we can also, again, with a lot of these questions, we can always follow up later via email for more specifics. But we're still getting some good questions in. So the next one I'd like to pose is, was your Swedish Edmonds TeleICU utilizing an existing TeleICU hub, and how much customization was required to serve Swedish Edmonds?
So yes, we do have an existing TeleICU hub, And that was what I talked about with the rest of the other campuses that have an ICU. We have the TeleICU intensivist covering those campuses as well. So when we added the Edmonds campus, we absorbed their volumes with our current patient population that we are already serving at our TeleICU hub. So with this model, we used a round and respond model, which is a little bit different than the other TeleICUs that we had prior. And that was because we had different type of software for monitoring the patients. With this program with Edmonds, we used the EMR, which is our electronic medical record, as well as rounding and talking to the nurses more frequently in a set rounding model. So it's a physician-driven round that we have when we talk to each patient's nurse at the beginning of the shift, and then we continuously monitor what the patient and what the nurse needs by looking at their plan of care and then viewing information in the EMR.
Excellent. So during the presentation, you guys mentioned using the InTouch TV Pro. This question was curious, what other technology did you use for your TeleICU workflow?
So other than the InTouch TV Pro, we use Epic, our EMR, and that had X-ray CTs that was integrated into the EMR. So that technology we used, a lot of it was heavily designed on the clinical integration that we worked with the Edmonds site and the workflows. So the type of workflows that are related and the interactions that are related between the nursing staff and the physician. So even though you do have technology, a lot of the design is dependent on keeping the program patient-centered and utilizing the technology of video and assessing patients to determine what the patient needs. So we do leverage the critical care nurses and the intensivists as well as using the video technology, but we didn't have any extra bells or whistles for this because except for using the telephone, but we didn't have another type of alarm or alert system for this round and response model of our program.
Great. Next question is asking if your data that you presented was risk adjusted, and if so, was a scoring model used?
Yeah, that's a fantastic question. So for the purposes of measuring, for the purposes of measurement for this pilot, we did not use a specific scoring model, and I would say that the data is risk adjusted to a certain point. So we are largely using the raw data for O to E mortality and length of stay that we get within our health system and our own extractions from our EMR, et cetera. However, we are closely monitoring in tandem what the case mix index is, what the patient acuity is in ICU to see if that has experienced any swings one way or the other that we would want to account for, because we know that those things tend to correlate and go hand in hand. So to answer that question specifically, we did not use a specific public scoring model or anything of that sort, but we were looking at O to E mortality, and then for length of stay, looking at the patient acuity kind of in tandem with that measure to best understand it, as well as looking at seasonally adjusted elements. So when we did that 6-month measure, I should have mentioned this earlier, so I'm appreciative of the question. We looked not only at pre-go live 6 months and post-go live 6 months, but also at the year-over-year post-go live 6-month period, so that we could take into account, that we went live with this right at the beginning of summer, and we often don't have quite as high acuity in those months as we do in the winter months. So wanting to make sure that we didn't see an overly favorable comparison just because of the time periods we were comparing.
Great, that was really insightful. And then this next question I think is actually related to that, and it was asking about the cost of care per patient and per bed, including the technology costs. But I think specifically what they were trying to get to was the amount ascribed to a decrease of length of stay per day related to the benefits you saw of using a TeleICU and how we arrived to that.
Yeah, so I'll answer that question. It's an excellent one. I'll answer that in a couple of parts here. So I think we've touched a little bit on kind of how we were addressing assigning or attributing a value or an algorithm to looking at the decrease in cost of care gained through reduction in length of stay, just looking at the average cost of care per patient day at that given ministry in terms of staffing and room and board costs and supply costs, that kind of thing. So I think we've addressed that. I did want to also just address the cost per patient per bed of a program like this. And with TeleICU specifically, as well as with most other telehealth programs, part of the cost benefit that we tend to see is in the ability to what we refer to internally as fractionalized FTE. And in being able to have one virtual physician who is covering multiple sites and thereby spreading the cost of that professional staffing, as well as same applies to the TeleICU nurses, being able to spread that workload and cost of professional staffing across multiple sites of care to be able to deliver exactly the amount of care that they need based on their census without having a full physician shift on site that might be underutilized, so to speak. So I think that's part of what this cost of care per patient per bed question is referring to. And so with TeleICU, we're able to see pretty good efficiencies in terms of that staffing ratio as compared to what we would see bedside. So that's a huge cost win in terms of staffing. And then part of that question that I heard, Scott, was in terms of the technology, and I will say that that was definitely a benefit that we saw with this program. That and this is just kudos to InTouch Health to making such great technology that's so clinically applicable in this kind of setting, available at a relatively low price point. In our experience, based on what we see in industry, that it was the startup cost to actually get the infrastructure in place to run the clinical elements of these programs was relatively minimal based on expectation.
Excellent, thank you. So I think we've also had some great questions around the success of this program, and then we've talked about expansion in other service lines and locations, but would it make sense to expand this program beyond just nocturnal hours to 24/7?
Yeah, that's another great question, Scott. So I think generally the philosophy is we'd want this program to go where there's need and demand for this kind of service. And I think generally speaking, no one tends to say no to additional support. So I definitely think there's an application for this kind of service to move into a daytime model as well. We have had some conversations, some interest in doing so, but because we want to be able to take advantage of that core value proposition of the ability to fractionalize FTE, we want to make sure that we've got significant demand enough within our system or our external partner sites to look at opening up a day shift before we do so. But we often see that fractional FTE benefit being seen even more fully with a daytime model, and that's in part because at many sites they do have some element of boots on the ground staffing, whether that's a full 12-hour intensivist present or an intensivist that may be there for 6 hours of the day or 4 hours of the day or something of that sort. They're often able to support one another or be more of a backup while that boots on the ground person is present. So we're often able to see higher ratios of beds to clinicians in the daytime space. So I think it's definitely attractive from that standpoint. And I'm borrowing this from a presenter that I heard at a conference earlier this year, but I think a really great way to think about this, especially as it pertains to daytime support, is thinking of it in terms of what I've heard described as the embers theory, that the TeleICU often is so beneficial in helping to watch the embers before they become fires, so that the folks that you have on the ground are best able to focus on the things that have already become fires and their most acute patients, while knowing that there is someone highly skilled and trained who's keeping that watchful eye on everyone else on their floor, so that they can truly focus. So I think that would be more the application. hopefully that helps.
Great, thanks. This has been a really insightful panel. We're starting to get to the end of questions submitted, so I'd like to encourage everyone, if you have questions that you'd like answered now, to please submit them. So this next one is, how many and what staff members on the patient end were needed for education and training on telemedicine equipment?
I'll take this one. So for our clinical integration and our clinical discovery, we went on site at the Edmonds campus to meet with the staff and to create our workflows and really design that program with them. And we also invited their staff and their leaders to come to the TeleICU hub to see what the equipment looks like on our side. So before this, we had the application installed in our TeleICU hub, and then we also had access to a test environment, a test room, so we can show folks, okay, this is how the equipment works. And then we basically did testing with the caregivers at the bedside and also mock drills to go over a scenario or a case where they activated the InTouch equipment. So with that, it was mostly done by a huge group, not a huge group, but a group of nurses during one of their education in services. We had the luck and the timing of another initiative going live at Edmonds, so they combined the training for that with our training, so we had a wider audience of nurses available to participate in our testing and our mock drills. So the technology is really simple. It wasn't a hard lift for either staff to do the mock drills, and that was very appreciative, because when you're utilizing the InTouch equipment for the very first time, it's like riding a bike. You don't forget how to use it. So the training and education was fairly simple, and it's more like plug and play. So we did appreciate that, and that helped ease the comfort of using the equipment, which does help with the relationship and the ease of access to call the nurse or call our intensivist and not worry about the equipment working or not or failing in between. It was just something that the nurses were able to do without using a lot of steps to activate the program.
Terrific. Thank you, Caroline. So this next question is asking to discuss your teleintensivist staffing model, and specifically how many patients or ICU beds can a teleintensivist or a TeleICU nurse support?
Yeah, that's a good question, and I would say that we've done a lot of analysis to kind of understand where others are at, and I won't say that this is like an industry accepted standard by any means, but it seems like most folks that are performing this kind of care tend to coalesce somewhere in the range of approximately 80 to 120 beds per intensivist, and somewhere in the range of about 30 to 45 per TeleICU nurse. Important to note that's beds, not census, not heads in beds. That tends to be sort of the norm. And we're seeing still about in that same range. And I do want to note that, because we were running a new model of care, we wanted to be especially cognizant of those ratios and ensure that that we were setting ourselves up for success until we had more fully trialed this, and not assuming that folks were working at 100% capacity all the time, because that's just not a recipe for success. So wanting to make sure that we had a little bit of leeway there.
Thank you, Kate. So one of the final questions that I'm seeing right now is asking how much customization of workflows is needed for each supported location, and how do the clinicians in the hub handle this variety?
So we have workflow templates that we share during clinical integration, and that's our standard of work that we align with all our sites. And so it is customized as far as who do you call, when you call, what are the phone numbers, what is the process for admitting, what is the process for transferring, and what is the process for physician handoff from day shift to night shift. We have those templates, and we try to keep to that, and we work with the site to fill in the blanks for those workflows. And that way it makes it easier for the clinicians in the hub to know what the basic templates are for the workflows, and then they can look at our provider handbook to see the minute differences between who to call, when to call, and for procedures, who can be called in to come at the bedside. So those are the types of questions that we go through during clinical discovery and clinical integration. So it's nice to have a standard way to align the workflows, and we work that all out in the design sessions.
Awesome, thank you. So those are all the questions that I've seen come in right now. So I'd like to give a big thank you to our two presenters today. And if anyone has any additional questions or for more information, they can please feel free to contact us at this email address of questions@intouchhealth.com, or the presenters directly at their email addresses that are located in their bios. Also, for more information on this specific topic and additional topics on telehealth, I would encourage everyone to please visit our website to look at the Telehealth Innovation Forum that will be taking place next month here in Santa Barbara, as well as to visit our website for additional recordings and a list of upcoming webinars that we will be hosting. So thank you everybody so much for the call, and everyone have a nice day.
Thank you.
Thanks all. Bye.